diagnostic criteria for TMD, the DCTMD, as the template or baseline, I should say, or background, but the foundation, that sounds is a better word, to explain to you uh, the criterion that you can implement in order to arrive to clinical diagnosis of the most common TMD conditions, and those DCTMD diagnoses were supported by validity estimates based on sensitivity and specificity, which makes it very unique in a base, because not every single diagnosis that we deal as dentists have that level of clinical validity. So if you think a little bit about it, we are talking about that pyramid of knowledge that you've been exposed to, in which we are, as high as we can in that pyramid. In addition to those most common DCTMD, we mentioned to you as well, or we introduced to you other diagnoses that are not validated, but not because they lack of validity, we are going to ignore them, because then we will have to ignore a lot of stuff. So these other diagnoses are diagnoses that you have to keep in mind as well, but being aware of the limitations that you as clinicians are going to have when you provide a non-validated versus a validated. And we highly stress that you should be reading your textbook, and the textbook for those previous two lectures were chapter 8. Today and the next class, we will be now talking about other orofacial pain conditions. And pretty much in your textbook, we are talking about chapters 4, 5, 6, and 7. And prior to the TMD were chapters 2 and 3. So remember, you have to keep up with your reading. So as I mentioned before, today and next class, we are going to be talking about other orofacial pain conditions that you may be encountering as clinicians, as providers, but at the same time are conditions that when you are taking your history, you have to be thinking about it, because they may mimic conditions such as TMD, and many times it has been documented in the literature. Many times they've been treated as TMD, they've been misdiagnosed as TMD, and in fact there are other orofacial pain conditions that you have to be aware. So now give me 1 minute to find where I have to put the mouse, or to place. I think no. Okay. Mouse doesn't work. Okay. So, within all these chapters that I mentioned to you, I am summarizing here the classification that is presented in the textbook by the American Academy of Orofacial Pain. And we talk about vascular and non-vascular intracranial pain disorders, primary headache, neuropathic, intraoral pain, temporomandibular disorders, which we cover extensively, cervical pain disorder, extracranial, and systemic causes of orofacial pain. Obviously, for the graduate student, to give you a reference, takes 2 years to go through all these. What are we going to do is to introduce you and highlight the major characteristic or the main characteristics that you should be aware about it. So let's start with the vascular and non-vascular intraoral cranial pain disorders. And probably the frequency or the prevalence, or how frequent you will be exposed to this possibility of having intracranial conditions is going to be not as high. And that's because of the prevalence of it, and mainly because probably these patients may be seeking care with the primary care physicians. But it's possible. It's possible that you will be the individual in your dental appointments and when you are providing patient care, that they will give you an idea about their headaches or about the pain that is within the head and neck region, that now you have to say, this doesn't sound like an odontogenic pain. This doesn't sound like really a TMD. This probably is a vascular or not intracranial pain condition. And something that is really striking that I want you to remember is when individuals are complaining of headache, ask them to describe that headache. And one key question is this the worst headache of your life? Is this something that you never had experienced before? And in fact, if you call your physicians or you call your neurologist, if you have one or a neurology practice, that will be the screening question to determine if they want to see you right away and if they want to send you to the ER right away. If it's the worst headache of their life and you have never experienced anything like before. Something to remember as well is this acronym SNOOP, SNOOP. I always put an E in front of the S, so I have to think about SNOOP. So don't put an E, but anyway, which means that the individual is going to have some systemic symptomatology. It could be, for example, fever, one of them. Is going to have some neurological changes. That's why you do, screening of your cranial nerve. But they may say, I cannot hear well, I cannot smell well, I cannot talk well. That's a tough one, right? Suddenly it started. It was something that they have never experienced before, and boom, it's coming now. The onset is after 40 years of age. Although some publications talk after 50 years of age. And suddenly the pattern is not similar to any previous type of headaches. So, something that comes through our mind immediately, probably one of the, within that category, common ones is going to be an intracranial aneurysm. In my clinical experience, only encountered it once, and the patient was very lucky that could be treated with very minor post-surgical symptoms. But if a patient is talking about a pain, when the aneurysm is large and is not being disrupted yet, then patients will be complaining of pain above or behind the eye, and they actually describe that like a knife behind their eye. They may be experiencing some numbness, some weakness of their body. Some paralysis could be present, and some changes in the facial expression that cannot be controlled, as you can see in this patient right here. Or they could have double vision. Double vision is something that you always want to ask your patients for. When they break, when they rupture, because the vascular wall gets so thin that rupture and cause the hemorrhage, then suddenly it's a very severe and extreme severe headache. Patients may be, when you ask about associated symptoms, patients will be complaining or describing the presence of nausea, vomiting, obviously a stiff neck, sensitive to light, seizures, loss of consciousness, cardiovascular symptoms of cardiac arrest. So as you may realize very quickly, it's not just a headache, but you are having other combined symptoms. And at that time, you don't want to ask the patient, open as wide as you can without feeling any pain, because you are realizing that you are within a medical condition that is very, very serious. When they are very small, they actually may be there latent without causing any major symptomatology. And I mentioned to you that in my clinical experience, that I remember I only have one And that was the case. And then you say, so how she found it? Well, I wasn't that smart that I asked the questions that were important. What happened is in one of our clinical studies, we were doing MRIs, and part of the MRI was the whole head, and that's how we identify it. And we need to, call the patient, educate it, instruct it, contact the physician, and so on. The patient receive the right treatment because they may be found in other type of imaging that are not necessary for that. So that it is what it is. But going back to the main question is this patient describing the worst headache and something that they have not experienced before? Very common, by the way, about migraineurs when they call their providers. They ask, is this like any of your prior migraines? And when they said, no, I know it's something different. Notice that approximately 30,000 Americans per year suffer of brain aneurysm rupture, and it's hard to know what is the percentage of their prevalence among the non-ruptured ones. So keep it in mind, the worst headache, I never had experienced this before. Let's see, vascular and non-vascular intracranial plane disorders could be not only aneurysm, you could have neoplasm, and I believe all that is related to that, you see it with Dr. Tapia, but you could have hemorrhage, hematomas, edema, may have some infection process going on as well. The point here is that they are going to cause worse headaches, very, very severe headaches with some sensory or motor deficits. They should be considered right away, and as I mentioned before, you don't do a TMD exam and do range of motion. You have to contact their physician, or sometimes even send the patients right away to the ER. The characteristics, as I mentioned before, they are of abrupt onset, something that happens suddenly, and is going to interfere with them. So with their normal function. Something that is relevant about intracranial conditions as well is that they may interfere with the sleep pattern that the individual may have, and that they may actually get worse with positional changes, coughing, sneezing, and that's why sometimes the Valsalva procedure is done to see if that increases the pain. I'm just checking that I already said all this, but I already said it, so you can read the slide. Among these vascular conditions that can be intracranial or extracranial, we have one that is called temporal arteritis. And temporal arteritis, again, the frequency or the prevalence is not that high, but it's one that is very, 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 very important that I want you to remember. And it's the fact that when you ask the patient about, I have no letters in my slide, that when you ask the patient about, there it is, any associated symptoms, actually the patient is going to complain about visual changes that they actually progress over time. So this arteritis is an inflammatory process going in many arteries that affects as well to the temporal artery. And that's why in the pictures that you may see in textbooks and clinical photographs, you can see that there is a elevated or pronounced temporal artery, and sometimes by palpating over it, you may replicate the temporal headache that these patients may be complaining about it. So I mentioned to you, is part of a systemic condition. Approximately 15% is associated to a systemic condition, and women are more affected than men. that is after age 50s. I guess after 50, everything happens. Is presumed to be autoimmune. That's as much as is known, and that's why I have this picture here of blurred vision. So why this gets worse and worse, and it's because it's the lack of irrigate of irrigation will cause ischemia in the optic nerve and will cause ischemic optic neuropathy. So those are the individuals that able to be talked to you in the affected side. They will cover the eye because if they have that one, everything looks blurred, right? So we actually ask them, cover this eye, can you see me okay? Cover this eye, can you see me okay? And they will say, no, now everything is blurred. It is unilateral, and most of the presentations are unilateral, which is different. It's very different than the blurred vision that some people with migraine, by the way, may complain about it, because the blurred vision during migraine may be present during the actual migraine attack. And more than blurred vision is like a zigzag. The patients complain about seeing like a zigzag, but they will disappear after the migraine is aborted, versus the temporal arteritis, which the vision actually just gets progressively worse, progressively worse. And I always talk about this anecdote. One of my professors, Dr. Ahmed Woodman, who was the director of the TMD clinic many years ago, always told us the story of a colleague that called him and asked him, Dr. Woodman, what is the muscle relaxant that you prescribe for TMD? And he gave the name of the muscle relaxant. And then, like 2 weeks later, the same colleague called and said, Dr. Woodman, you are in trouble. That muscle relaxant made my patient blind. And he said to the colleague, no, you are in trouble. You misdiagnosed the patient. Your patient had temporal arteritis. It was not a TMD condition. So, I always remember that, and temporal arteritis is always present in my mind when I'm doing clinical assessments and when I'm doing my history of chief complaints, that it takes, in terms of time, most of the time, because that's when you are using your brain to figure out what's going on. So for temporal arteritis, patients may complain of masticatory muscle pain secondary to that. Obviously, they will complain of headache, blurred vision. Look at, I put it here on bold, or loss of vision. They will complain as well of a scalp tenderness, or they may have allodynia. They actually may feel pain when they are brushing their hair. Different, right? Tenderness and allodynia are two different terms. And because it's part of that systemic condition, you could have patients may complain as well, or refer or describe of having fatigue, weight loss, fever, etc. The first blood work that probably is going to be ordered for this is going to be the erythrosedimentation rate, which is going to be elevated in this patient. But as you know, erythrosedimentation rate is elevated in every inflammatory process that is going on. So it's like a first step, but it's not unique for temporal arteritis. The only way, or the gold standard, is going to be a biopsy confirmation, but sometimes the physicians will not do the biopsy because it's very invasive, as you can imagine. But in addition to that, it's not going to modify the treatment. So really the treatment comes in the next slide, which is the use of steroids. And sometimes they may take a part of the artery that is not being affected. So it's going to be given the biopsy will read negative and impact the patient is symptomatic. So when we suspect that this is the case, we definitely contact the primary immediately, or if the patient have a rheumatology already into their list of provider, we would contact the rheumatologist or the ophthalmologist, mainly the rheumatologist. I pretty And the course of treatment is going to be put the patient in high dose of corticosteroids to reduce the inflammatory process that is going on and help the patient. Okay. Oh, it's working. I don't need the mouse. So remember, for the vascular and no vascular intracranial, what I want you to remember is the fact that the individual is going to complain of the worst headache, nothing like this before, that is going to have a secondary or an associated neuro, sensory or motor dysfunction. And specifically for temporal arteritis, we want to be sure that there is no involvement with the vision. Or in fact, if there's an involvement, that is going to allow us to think more about that condition. Now let's talk about my favorites. My favorites are primary headache disorders. And among them, we will be talking about migraine headache, tension type headache, and the trigeminal autonomic cephalalgia. And as I mentioned before, we can spend 2 hours only talking about migraine. So this is an introduction. Please don't forget to read the textbook. But you have to be aware about it, because you, again, may have a patient coming complaining of migraine, complaining of what's supposed to be a TMD condition, and in fact is a primary headache condition. In addition to the fact that many of the patients that we see, I would say 99% of the patients that we see have comorbid conditions, being primary headaches the most common comorbid conditions. Any comment, Dr. Crow or Dr. Katu? No comments. So primary headache disorders, they are neurologic of vascular origin, and they have different mechanisms, although not necessarily well understood. If we specifically talk about migraine, there's the WH, which as a country we belong, we are back to the WH these days, describe migraine as a disabling disease, and ranks the migraine as the most prevalent disabling long-term neurological condition when taking into account the years lost due to disability. So it's not just a headache, okay? Migraines are serious primary headache conditions. Around 15% of the US population, based on their surveillance studies, are identified with migraines being more prevalent in females than in males, as you can read the numbers. And having a migraine for this group of individuals that suffer of migraines is very sad, because having migraines increases the comorbidity for psychiatric disorders, mainly depression, increases the likelihood of having sleep disorders, epilepsy, and stroke. In addition to the fact that some of the medications that are used to avoid the migraine give an additional increased risk for a stroke and other cardiovascular conditions. So these are the references for all these statements, and is well described in the chapter as well. So why people suffer of migraines? Okay, so there is no doubt that specifically in the paraplegic migraines and in migraines with auras, and we will talk more a little bit in a few minutes, there is a very well established genetic component, okay? Nevertheless, the migraines without aura, they don't have such a statement, is not as firm in terms of the genetics. So no doubt that the environment have a lot to play, and the interaction environment and genetics, right? But when we try to talk about what causes a migraine, it's really a neuroinflammatory process and an increased central sensitization that the individuals experience and are exposed to, and that's why they are having these horrible headaches. And meaning that the whole ascending and descending pathway of pain are altered, facilitating the ascending, causing indivision in the descending, and really an increased exposure or an increased response. That's the main question. The best word is an increased response to all excitatory process, which is being described as a wave that is happening in patients with migraine. And this wave is really what is could respond or could explain why individuals actually have an aura. They know that the pain is coming. So it is not only because there is a vasodilation, vasoconstriction of the vessels, which for many years we thought that was the case. It's not only cortical depression followed by excitation in the central nervous system, but it's really something that evolved and that now we understand more the neuroinflammatory process and central sensitization. And this is not, by the way, it's not really unique to migraines. I think it's common understanding for many chronic pain conditions. More so and more recently, the role of the CGRP in migraine has been stressed in the most recent year. I know this reference is from 2006, but if I search, and I did search last night, as you can see, 2019 there, but a lot of the emphasis has been in these CGRP neurotransmitters because they have a lot of response or implications in the vascular response and in the autonomic response in the individual. So a lot of the medications that we have right now, and I will get there when we get to meds, are concentrated in monoclonal antibodies to block this CGRP neurotransmitter. If you go to the International Headache Society classification, as you can see, there is a lot of types of migraines. Are we going to remember all of them? No, because I only want you to remember, or we only want you to remember two, what is called and what is defined migraine without aura and then migraine with aura. Technically, both of them have common characteristics, which is that the individual is going to have these attacks that may last from 4 to 72 hours. When they go beyond, the individual enters in what is called a status migrainosus, which is maintained. And mainly unilateral. It feels like a bump in your head. That's the vascular component. The patient will say, "Doc, my head feels like it's going to explode. Boom, 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 boom. Like the heart is inside my head." They said that sometimes as well. Very intense, aggravated by routine physical activity. So these are individuals that cannot go to the gym, cannot jog, cannot sometimes even cleaning their house and doing activities will trigger that migraine or will make worse the actual episode. But something that is very characteristic and you must remember is that with associated factors or associated symptoms, the individual is going to say that they have nausea and photophobia and phonophobia. So when you come to TMD clinic, and we traditionally call it TMD clinic because to say TMD and orofacial pain clinic is very long, but we do see more than TMD. But when you come to our clinic, sometimes you will see the lights down and we have a little yellow light turn on and you say, "Oh my goodness, they are so romantic here." It's nothing about being romantic. It's about the fact that the patients cannot tolerate the white light. And obviously, if they are having a migraine attack, we probably will not do any treatment, but we don't want to trigger the migraine with the white lights. Sound, we cannot do much while we work in private rooms where kind of blocks the sound a little bit, but being in a high traffic area is very difficult to control the sound. So everything that I said is in all those words that you can see right there, but definitely during the headache, nausea or vomiting, and phonophobia and photophobia.
Dr. Gonzalez?
Yes, and who is talking?
Cody.
Hi, Cody. How are you doing?
How
Welcome.
are you?
Doing very well, sir.
So I had a patient yesterday in the pediatric clinic that complained of migraines within the last year because of the virtual learning and just staring at a computer screen all day. Have you guys seen an increase in cases of migraines due to that recently?
Um, I haven't in terms of complaining of increased migraine due to the expose to the computer thing. Uh, what I can say first, you mentioned pediatric patient. It gives me the opportunity to mention to you, Cody, that the prevalence in the pediatric population is less than in the adult population. That's something important to know, and it's being described up to 3 to 7%, depending on the age range. Definitely the 3% for those who are 7 years and younger. Uh, and the same pattern goes to very older adults or elderly adults. The migraine, the prevalence goes down as well. So you can imagine this kind of normal curve, which the two extremes goes down. But to answer your question specifically, no, I haven't seen any pediatric patients in our clinic complaining of more migraines. But that's a good question for the neurologic, where they have all the headache patients. We have seen a lot of patients complaining of more clenching, grinding, muscle pain due to the whole stress with COVID. Yeah. But maybe Dr. Crow or Dr. Katuf can have a different comment.
No, I haven't heard of it either.
You are on, Ali.
Yeah, I said no. To my knowledge, I didn't hear about it. Maybe the neurologist will have to get.
Good question, Cody. Good question. And welcome. There are some students, they promised me they will say hello today because they were in clinic last week. Anyway, the next group and the second group that I want you to remember about migraines are migraines with aura. And the difference between this one and the previous one is really that you are going to have this aura, right? And the aura is going to be a sensory change. Mainly, it's going to be visual that they experience, these patients experience before the pain comes. And imagine a patient telling you, I know I'm going to have a headache. That sounds like how you know that, right? You are making it up. No, they are not making it up. It's a very well established phenomenon. Some individuals not only feel or can have visual changes, sometimes it's a smell. They can smell things, or the smell, that sensory aspect is very acute before the migraine per se comes in. So that's something to keep on mind. And everything else pretty much is consistent with what I said before. They still have the nausea, the vomiting, is very severe headache. It lasts over 70 up to 72 hours based in the international classification. So there is something I want you to be aware. In general, migraines have a familiar story. I'm a migraine sufferer, so I remember my mom and my grandma when they have migraines. We couldn't make any noise in the house, and everything have to be off. And then I got it. Likelihood of my daughter getting it is going to be very high. Triggered by food are environmental agents, right? And here is stress, as Colin mentioned this day, stress and being 20 hours in the computer, could be one of them, but stress definitely triggers that. It's mainly in females, and it's been associated with abrupt changes in serotonin, and actually with abrupt changes in estrogen as well. Estrogen. So I mentioned about the World Health Organization. We don't have to repeat that. It's very causes a lot of cost.
Do you have
Every
AAA
chronic
batteries?
pain condition is
I don't think
quite
so.
expensive
My batteries are
in
both
terms of
dead.
treatment
Oh,
and people seeking
We have the
treatment,
battery we have. It doesn't
and
work.
interferes
It's
with
already been.
all
have-
social,
Buy some tonight.
academic, and life in general.
So maybe I still
How they
play
are
them.
treated, you must remember the
I
following.
should roll it back.
Treatments are divided either preventive treatments or
Don't remember.
abortive treatments. Okay. So the preventive makes sense, is to
Yeah.
prevent the migraine, right? And among your preventive, you have your
Number
beta
two.
blockers, your calcium channel blockers, your antidepressants, anti-anxiolytics, and the botulinum toxin A, which has been approved by FDA for the prevention of chronic migraines. In terms of abortive, you take a pill for the headache to go away. You have the ergotamines, which are not used very commonly. I believe the neurologist thinks that that medication it will go out very soon. But you have the triptans, the family of triptans, and there are many of the triptans. Am I going to text you for a specific, Initrex is what type of triptan? No, that's not the idea. But you have to remember, triptans are abortive for migraine, right? And they come in injection types, injectable, sublingual, dissolving tablets, regular tablets, nasal sprays, combined with non-steroidal anti-inflammatory. But the thing to remember is triptans are abortive treatments. With that, taking triptans come some side effects, and some of the side effects, they are very potent vasoconstrictors. They are going to actually, it may cause some rigidity of the muscles, which includes the masticatory muscles. So the patient can tell you, I have this horrible pain, and then my muscles get tight. And if we didn't have the story that they suffer of migraines, that they take these drugs, and that maybe that tightness of the masticatory muscles could be due to the intake of these triptans. Triptans are limited for the intake to 2 tablets a day for individuals taking triptans, and they don't want more than 3 days in a row taking triptans. Why? Because they increase the risk for cardiovascular events. So if you have a patient that in the medical history said, yeah, I take this as needed, and I, pop the 6 or the 9 that I receive in 1 week, it's not good. Now that it's not being taking the medication properly. 1, 2 is increases your risk for cardiovascular. 3, you have the pharmacist in the floor. You can contact your pharmacist to educate better your patients and establish the need to contact their physicians. The other thing that is relevant to know about triptans is that sometimes they are taken more than one triptan, and it's because there are 2 types of triptans. They are the short acting and the long acting. So short acting usually are prescribed to really abort something